Good afternoon, friends, respected chairpersons. At the outset, I'd like to thank Rishi and the entire scientific team for having invited me here, and Dr. Rajat for letting me speak here in his place. Since we've got just 10 minutes, I'll give a very fast presentation. Basically, it's on how I manage severe acne scars. It's not moving. Though this has a lot of plans, it's just to tell you that what you really need to know when you have a case with very severe acne scars. I have no financial interest to declare. In fact, most of my instruments are quite cost effective. This was one of my worst patients which I had about 3 years back, and we all know that acne scars, what I want you to really remember that acne scars are polymorphic, and you have, just as you have 4G now, you have to know 4Ds or 4 dimensions of the acne scars, the shapes, the size, the depth and the texture. That is most important. And often they coexist in the same patient, so you require multiple treatment modalities. What I will be basically concentrating upon are the depressed, the box scar, and the bridging scars and tracts. These come in the most severe category. So these are the type of depressed acne scars. These are the hypertrophic scars, and again I'll be concentrating my talk on the bridging scars. This is the Goodman and Barron scale, and I will be speaking basically on the severe scars that cannot be flattened even with stretching the skin. This would be a grade 3, whereas this would be a grade 4, very, very deep scars. There are a lot of techniques which you can use them, but again, what really helps in the deeper scars are subcision, the punch excision techniques, and if they are very severe, you have to excise them. They can be followed up by fat and fillers and then followed up with lasers or radiofrequency microneedling, which has been increasingly used nowadays. So this is my algorithmic approach. For mild grade 1 scars, you can use chemical peels, and if this doesn't work or you want additional improvement along with topicals, you can use an IPL or a non-ablative laser. A pulse dye laser is good for the erythematous scars, provided you have it there. It's quite an expensive laser. In the moderate grade 2, you can use subcision, cross and microneedling, and the beauty of all these techniques are that they can be combined together, and then you can follow it up with the fractional CO2 or the erbium YAG laser. In the moderate grade 3 acne scars, you combine subcision along with the punch techniques, and you can also combine them later on with the fractional CO2 or the erbium YAG laser. Why I place the fractional CO2 or the erbium YAG laser later is because if the scars are very deep, you have to elevate them with the punch technique. Then only the laser becomes more effective, because if you use a laser right on, just because you have a laser, you'll find that they won't improve so much. And I get a lot of patients who say that they've had laser done somewhere outside, but they've not improved much, and that is because they have very deep scars. And the grade 4 scars, again, you need to combine all the different techniques. So subcision is the all-rounder. You should be very good at it, and it's a good modality for any type of depressed scar. The principle is to break the fibrotic strands which lie beneath the scar and tether the scar to the underlying subcutaneous tissue. And you can use either a hypodermic needle or a no-core needle. Basically, I prefer a hypodermic needle because you can get different sizes and you can twist them to suit the scar type. For example, you can, if your scar is long, you have a linear scar, you can make a bend here. So, and if your scar is very fine, like an ice pick scar, you can use a smaller gauge of the needle. If it is much thick, you can use an 18 gauge needle. And you can, now when I do a double bend, this is a Z-shaped bend, and you can mount this on a 2cc syringe, and it becomes a very good instrument for doing the subcision. Time permitting, I'll show the video later on. But don't be very aggressive, because you can get complications, you can get bruising, you can get even nodule formations which can persist and which then have to be treated with intralesional triamcinolone acetonide. This is the cross technique. You can use it as complementary to the severe scars, especially when the patient is left with ice pick scars. And I'll basically now concentrate on the punch technique for the deeper scars. The whole principle is that when you have a deep scar, be it a box scar, you have to excise the whole scar out. If the surface texture is normal, then you just have to do a punch elevation. That means you just lift the punch up, you don't remove it entirely. But if the texture is abnormal, it is atrophic, then you remove this punch out and you replace it with another graft taken from either the post-auricular region or from the buttock region. And if you abrade both the donor and the recipient side, it is called as an abraded punch grafting. And if it's a very large scar, then you have to excise it and suture it so that you convert a round, large scar into a thin, linear one. So that is the basic principle. A punch flotation is you take a punch the size of the scar, go deep right up to the subcutaneous tissue because you want the scar to be lifted up. That's what it's called as a punch flotation. Then you pinch up the skin or either just pinch it up so it remains up, or use a needle, the tip of the needle, to uplift the scar, and then let a coagulum form at the bottom and give a very light dressing for 3 to 5 days. So this is what is punch flotation. In the abraded punch grafting, you abrade the epidermis of the donor area, you take the graft, you abrade the recipient side, you excise the deep scar and then fit in the graft. So this is the donor area, this is from the buttock. You just abrade it lightly, so you remove the epidermis and you have a pure, just the dermis. You take the graft, and then this is a patient who had a bridging scar on the cheek, and she had a lot of deep scars. They are marked, excised, and then you put the abraded punch grafts here, and you can see that a slight hyperpigmentation is there, but it has lifted up. Then you can follow it up with a laser if you want. Same patient on the other side, and this is the abraded punch graft. So basically, it's a dermal graft which you are placing, and this is what you get. Some other patients of mine, it's important to mark the scar with the patient sitting up because some of the smaller scars will get effaced. And microneedling is a useful technique. It's complementary, though it cannot be the only technique. If the scars are very severe, you could either use a roller or derma stamp, and personally I prefer the derma pen nowadays. So this is the derma roller, but you can combine this with the subcision as well as with the laser. Or you can have an instant lift. If you have a patient who's getting married, the deep scars won't go, but you can just give a little instant lift. It will make them less noticeable. And though it is most useful for the rolling scars, you should stretch the scar and see. If the scar vanishes or goes down significantly on stretching the skin, that means the scar can be very easily filled up, either with a filler or the fat. I prefer fat because it's cheaper. So you do a subcision, and you can use a temporary filler, preferably like hyaluronic acid. So this was a patient who was getting married in just 3-4 days, and I did a subcision and then filled it up. Or fat transfer, this is the fat being taken up. I prefer, most of them are thin males, so I prefer taking it from the posterior thigh. This is how the fat is there. And these are the large lipoatrophic scars. There's a lot of fat atrophy which you can fill up with using fat. You need very high volumes, and the advantage of fat, it also contains adipocyte stem cells, which also helps. You can see even the quality of his skin has improved. Another patient who was really depressed because when he used to smile, he used to get very deep grooves here, and he always had a sad face. And this is immediately after the fat. And this is after 3 months. The fat you have to repeat. What I generally do is I repeat every month for 3 months, and then I give a gap of 6 months to 1 year, and I call a patient for a touch-up if required after 1 year. But if you don't do a good subcision, you can have pockets like these. This was a fat grafting done by a plastic surgeon without subcision, and these pockets really remain, so it becomes very difficult to treat such patients. So a good subcision and making a good pocket is very important before you do a filler or a fat. Then PRP is another technique which may help in patients who really are not collagenizing even with the lasers. If you feel the patients are not improving, do a PRP, and then you can do your techniques. But lasers, I feel, are just the icing on the cake, especially for the severe scars. You can have ablative as well as the non-ablative lasers. But there is again a downtime here also which is involved for at least a week. For the papular scars, you can do radiofrequency ablation. You take a fine wire electrode, and these scars are more commonly found on the nose, on the chin, and you just go deep inside with the Elman radiofrequency in the cut coagulate mode. And this is the improvement you can get. And these are some of the newer techniques which are being used. Focal acne scar treatment is similar to the cross technique, except here, instead of TCA, you're using the CO2 laser as in the pinpoint mode. So how do you combine the techniques? You can combine the cross with the subcision. These are some of my patients where I have used combination techniques. So this is what you can do. You can do them even in the same session to save time. And these are some of my really tough cases. This was a patient who had isotretinoin flare. We treated his acne, and then this is the scars which he had. A lot of lipoatrophy, a lot of atrophic skin. He developed hypertrophic scars, and this is the depigmentation following the intralesional steroid. And we treated him with a combination of subcision and microneedling and followed it up with fat. And you can see that he's improved, even the skin has improved. So this is the results you can get with the combination techniques. This is another patient.
Niti, can you wind up?
Yeah,
please?
I just have. Yeah, it's the last of my slides. This is, he never moved out with this handkerchief covering his face all the time. This is, first the cysts are treated with phenolization. The phenol is being neutralized with povidone iodine. And this is the same treatment, and he has improved. But this is one of my really tough cases. He has literally the whole face is covered with these bridging scars. You have to remove all these small bits of skin, and the scars are excised. These are the abraded punch grafts, and this is how he's been improving. These are still, sometimes they tend to have pigment, and then gradually this is the other side. So this patient still has a long way to go. He's lost most of his beard hair, and we have just done a little hair FUE on his beard area. We are awaiting the results. So this is the algorithmic approach. You have to treat each scar individually. And the carry home message, it requires a multimodality approach. Combine all your techniques, and you can use lasers, I feel, not initially. If the patient has very severe scars, you need to excise your scars before you start the lasers. You can always contact me or email to me. This is the book which I have given most of my tough cases. Thank you so much. Do we have time for just a minute video?
No, actually
okay,
not.
Fine.
We are already running very late.
Sure.
Sorry for not
That's
allowing
fine.
you.
Thank you.
Next speaker in this session is Dr. Rajat Kandhari. He will be speaking on liquid facelift.
Thank you, sir. A big thank you to the organizers for inviting me for this session and giving me an opportunity to speak on this topic, the liquid facelift. I'd appreciate if you respect patient privacy and dignity. How often do you see this in your practice? Doc, just do this for me, just lift me up. I see it fairly often nowadays. The liquid facelift, what will we cover in 10 minutes? The what and why of the liquid facelift, current concepts and perception of beauty, the aging process and relevant anatomy, the facial assessment, and the technique. A liquid facelift is a technique used for injecting advanced dermal fillers, sometimes in combination with Botox, to lift and contour facial features. It may be used for a gentle lift of the overall facial features, reduces wrinkles, creases, and folds, restoration of the natural and curved facial contours, a more rested and energetic look, and a friendlier smile. Why the liquid facelift? Because Botox and fillers appear to work synergistically, which results in greater efficacy and patient satisfaction. Botulinum toxin reduces the dynamic component of the right eye, thereby extending the life of the filler, and it may help in decreasing skin roughness to produce a smoothing effect that may be enhanced by the addition of soft tissue fillers. What is the current concept of and perception of beauty? If we see these 6 pictures, which one do we find the most attractive? Number 5 and 6 are the usual answers to this, and it seems that regardless of nationality, age or ethnic background, for the most part, people universally share a sense of what is attractive. An attractive face is supposed to be oval and have a good OG curve in females. The OG curve is an architectural shape which consists of an concave arc flowing into a convex arc, creating an S-shaped curve. We've shifted from a 2-dimensional to a 3-dimensional focus. Earlier, we used to merely work on hyperdynamic lines and work on the muscles to cause immobilization to decrease those lines. And now we have an increased comprehension and appreciation of the loss of volume and its effect on treatment approaches. Affecting facial beauty has gone far beyond wrinkles and furrows. And if we see this lady who's 65 years old, this is after correction of lines and folds, and this is after correction of volume and structure. So she looks much more beautiful. A review of literature on facial beauties identifies 7 key facial features, which by Dr. Arthur Swift have been named the Magnificent 7. 4 of these are amenable to contouring with injectables, which are the facial shape, the eyebrow shape, the nose, and the lips. The others can be improved with topical agents, energy devices, makeup, and hairstyle modification. And if we do that, we can achieve results such as these. This is before, this is after treatment number 1, and this is after session 2. And after makeup and hairstyle, the patient improves substantially. The aging process and relevant anatomy. There are 4 Ds to the aging face. So the triangle of youth, which is a full and wide mid-face, gets deflated, which we need to reinflate. There is tissue deterioration, which we need to rejuvenate. There is descent of the facial envelope, which we need to lift. And there is disproportion, which we need to strive for proportion, harmony, balance, and symmetry. Certain areas of the facial skeleton have a strong predisposition to undergo resorption with aging, such as the mid-face skeleton, the maxilla and the piriform region, the superomedial and the inferolateral aspect of the orbit, and the pre-jowl area of the mandible out here. And these resorb in a predictable manner, and the resultant deficiencies contribute to the stigmata of the aging face. There are discrete fat compartments in the face, the forehead fat compartment, the periorbital, the cheek, and the jowl fat. And these are superficial and deep, and aging leads to abrupt contour changes between these regions, and as a result of volume loss and or malposition of specific compartments, which is why the face does not age as a confluent mass. The attenuation of these ligaments further adds to this process. These are the more important fat compartments. The superficial cheek fat compartments consist of the infraorbital, the medial cheek fat, nasolabial, middle, lateral, and the jowl fat. And the deep cheek fat compartments are the medial suborbicularis oculi fat, which is also known as the SOOF, which is out here, the lateral SOOF, the deep medial cheek fat, and the buccal fat. And the contour of the cheek is affected by the volume of the deep fat compartment, the suborbicularis oculi fat as well. The buccal fat affects the prominence of the jowl, and injection into this pre-jowl sulcus medial to this jowl fat is advisable for the augmentation of the chin area. So out here, this is attenuation of the orbicularis retaining ligament, loss of the lateral SOOF, and loss of the deep medial cheek fat, no anterior projection. Out here, there is adequate deep medial cheek fat giving projection to the cheek, and the buccal fat affecting the prominence of the jowl. And when we treat this patient and try to restore this fat as well as the periorbital area, we can achieve a good result with these, with the facelift that we are trying to. So better contour and an OG curve and a better anterior